we are very excited for our next presenter. It is Dr. Choutka, and he is from Saint Alphonsus, we say Saint Al's, which is a member of Trinity Health, which is located in Boise, Idaho. And he's going to be talking to us about specifically GammaTile therapy to treat GBM, and potentially talk about a couple of different clinical trials he may or may not. I do have a couple of questions for him myself, so that'll help us become more educated. I want to read a little something to you about his care philosophy. A physician I know once said, if you take care of the patient, everything else will take care of itself. And that has always been my philosophy. My patients can expect personal care as if they were my family. I don't feel for my patients, I feel with them. We are partners through the difficult times, setting goals and working together to achieve them. And one of the things that makes Dr. Choutka also unique is he gives patients his cell phone number. And we all know how important that is. You know, when you're a patient, you're a family, you're a caregiver, to be able to reach your healthcare provider. And so we thank him completely for being so eager to help and feel with his patients. So ladies and gentlemen, we are very pleased to bring you Dr. Choutka. We hope.
We hope.
Oh, there he is. Hi.
Hi, this is Ondrej. And thank you very much for letting me participate today and for having me. I hope we can see and hear each other. I have to say, I'm still not used to the impersonal meetings without being in person, but without this, you know, we wouldn't have events like this, which are wonderful. We can bring people together from many corners of the world. So
thank you.
It is wonderful. I will just briefly say that I've enjoyed the day. I had to be in and out due to normal person problems also. My kids are missing the passports to get home, so we'll see how it goes.
I want to thank you for being so flexible today as well. So really appreciate it. Thank you.
I'm personally from the Czech Republic, so I grew up actually in Eastern Europe behind the Iron Curtain, and I very much enjoy listening to Leo, who spent time at Radcliffe Infirmary, which is a place I trained also. So I wonder whether we have a few connections. But I ended up in Boise, Idaho, by a long route through England and Australia, and ultimately Mayfield Clinic in Cincinnati, which has taught me the passion for neurosurgery and care for patients with brain tumors and aneurysms. You know, my subspecialty background is in both cerebrovascular and tumor surgery. So that's my little background. We ended up in Idaho for the love of Idaho and in Boise. Not many places in the US where children can still cycle to school on their own without getting hurt or feeling unsafe. So, but I'm very excited about working here at Saint Alphonsus, and it has been a pleasure trying to build a comprehensive cancer center where we can provide cutting-edge treatments to patients. And you've heard a lot of talks today on various strategies on brain tumor care, etc. But ultimately, it really all comes down to the relationship with the patient, what they want, what they need, and trying to get the best out of a life that we get. We can only deal with what we get, and we all continue to hope for the best possible outcomes and best possible lives. And I think that's what drives all the speakers today in trying to just get another day or another month or another year. I think End Brain Cancer Initiative, the term itself, End Brain Cancer, is wonderful, and even though still utopia in the current day, it is definitely a goal to strive for. So I'm gonna share my screen.
Okay.
And know if that's showing up.
Yes.
Excellent. All right, so I've been tasked with chatting about GammaTile therapy, and it is a form of radiation. But we'll talk about that. First of all, I have no financial disclosures, just to put it out there, other than treating my patients. I think the brain cancer term is kind of confusing and all-encompassing, even though we're dealing with many different beasts. And that's why I think there's no single answer to end brain cancer. But really, in broad terms, when we're dealing with brain cancer, we're talking about either cancer that came from somewhere else, such as brain metastasis, or we're talking about primary brain cancers, malignant gliomas, and today a lot of talks were about GBM. But then also we're talking about benign tumors traditionally who turn into malignant tumors. And all of those encompass roughly the brain cancers as such. So finding a cure is a difficult task because there are many different cells, many different processes, many different treatments. We all put efforts in different parts of it. In my practice, I deal mostly with malignant meningiomas or malignant gliomas, but the brain metastases are really the most common cancer in the brain. So that is what we see the most in the population. So all of those have different standards, and you've heard wonderful presentations today on how these things are treated. The standard today for brain metastases or potentially surgery when they're solitary or treatable, tumor resection is then followed by stereotactic radiosurgery. So that's targeted radiation that's done at a delay, about 3 to 4 weeks for best outcomes. And this has been a significant improvement to previous whole brain radiation that we used to do, which had significant cognitive changes that occurred perhaps a year or two later, but it speaks volumes to our outcomes. People are now living much longer, and we can't afford to have those cognitive changes occurring. So we have been aiming for local control rather than whole brain radiation. When it comes to malignant gliomas, I'll use the term GBM, although this term will not be around for much longer. I believe our classifications will be changing based on cell types and genetics. The standard treatment is surgery. Obviously, the first surgery is what discovers what the type of tumor it is, and then followed by the STUDE protocol. And you've heard a lot about that today. I put plus other because there's a lot of effort in trying to improve the outcomes in GBM care and survival. And that's when we add a lot of other potential treatments, whether that's combination chemotherapy, whether that's GammaTile treatment of in-field radiation, or whether we add tumor field therapy, as you've seen in the previous presentation. The reason, whenever there are many different options, that means that there is no standard. We have not found the silver bullet, as they say, to kill the cancer. And this is why we have many trials and trying to find the optimum pathway for these patients. The reason, for those of you that know why the term multiform is, because there are so many different cell types within the tumor, and each patient has different combination of those cells. And during treatment, different cells get killed and different cells survive. And that really makes the treatment or cure of this tumor extremely difficult. And I'm sad to say that in 50 years of research and treatment, when it comes to a lifetime, we've made very little difference in our efforts. And that is the saddest part of certainly my professional life and my personal relationship with my patients. But it certainly doesn't stop us from trying to get further. And I'm hoping that one day we'll have a simple pill that we'll take and the tumor will magically melt away. The malignant meningiomas are commonly treated surgically first, again, followed by sometimes stereotactic radiosurgery, sometimes recurring surgeries, sometimes GammaTile therapy. And it again depends on the location of the tumor and the biology. Those tumors unfortunately can occur in skull base, and they're around important structures, and simply curing the tumor may not be the best thing, because removing all of it at the cost of a loss of function is a major problem. We think removing the tumor as a whole is the primary task. I would say removing the tumor without any neurological trouble is the primary task, because the moment we cause someone to be paralyzed or can't talk, we're actually shortening their life. When somebody can't move, the life will be shorter. So I think it is essential to not just be thinking about curing cancer, but also think about really the quality of life that we're achieving with those treatments. The combined thing with all those tumors is they tend to progress or recur. And you've heard a lot about recurrent glioblastomas today. And I think I may be on an island here, but I don't think it's a recurrent tumor. I think the tumor never really leaves. And so most of those are progressive tumors rather than recurrent tumors, irrespective of the MRI looking clean, as Leo has mentioned. And I think that is our task. You know, how do we make the progression the slowest possible? How do we keep the quality of life? And how far can we get? I do believe glioblastomas are really a disease of the brain rather than a localized tumor, and therefore ultimate potential cure will come from treatment of the brain, not of the localized tumor only. And this is where immunotherapy has made huge difference in other cancers. It just, we have a lot of difficulties in the brain due to blood-brain barrier and accessibility, and the huge variation of those tumors within each individual. So what is GammaTile? It is a surgically targeted radiation therapy that uses radiation seeds. It is really not a new concept at all. We have used radiation seeds and for other cancers, such as the most commonly used is prostate, where it's implanted directly. And the reason it has been successful is because it avoids the complications of the radiation rays passing through healthy body. So it's delivered directly to the tumor bed. Similarly, in brain tumor treatment, we have used seeds, radiation seeds in the past, but it's just a difficult task in trying to line them up within the cavity after the tumor is removed. What GammaTile is those seeds are spaced appropriately for the right dosing, and they're embedded in a absorbable sponge, which is made of collagen, which really allows for very simple placement in the resection cavity. It has very predictable drop-off of the radiation from distance from those seeds and avoids those external complications of radiation. A lot of patients will have thinning of the scalp. Some will get infections when they need recurrent surgeries later on. It makes it difficult for them to heal, because the soft tissues have really taken a beating. Sometimes when patients do achieve the goal of long-term survival, they end up with thinning of scalp to a point where their bone is exposed. And those are nasty complications in the long term. So the idea here is to deliver the radiation directly to the bed without the complications of the surface, and doing it in a timely manner. It occurs at the time of the removal of the tumor. So this is when our microscopic disease of the tumor cells is at its lowest point. Because even 3 weeks later, when we would normally wait for conventional radiation, there may be tumor progression already. So this is the simple idea behind it. And on the slides, you can see what the tile looks like. And really think of them as bricks, and we're lining up the wall of the cavity of the tumor resection. Currently, the treatment is FDA cleared for any malignant brain tumors. So all of those that I mentioned can be treated. Most places using them for recurrent tumors requiring surgical treatment, but they are really cleared for any malignant tumor. I will mention that it's difficult, perhaps in the cases of GBM, to really be doing that at the onset, because the diagnosis has not been made. So when we first open, we're removing tissue, and we can have the pathologist look at it, at the time of surgery, but it is quite possible that the diagnosis will be different once they are able to do all their staining. So that's why it is first used in patients with recurrent tumors where the diagnosis is already known. Boundaries to be pushed still. I'll give a simple example here of what that looks like. These are scans of a patient who came in a coma and had a large tumor in his left frontal lobe. It is based on the dura, which is on the outside, the covering of the brain, with a lot of swelling around it. So this could be anything. This could be a dural-based metastasis. This could be a malignant meningioma, or it could be a glioblastoma. He underwent surgery with good clearance of the tumor, and the post-operative MRI is below. And the diagnosis came back as glioblastoma. So he then underwent STU protocol, and a year later ended up with progression of tumor, but still in a localized area, still in the area of the frontal lobe, without spreading all around. So we had no diagnosis, and we therefore decided to treat him with repeat surgery. And at this time, because he's already completed radiation, we have placed GammaTile. And these CAT scans here show the little seeds that are lining the cavity where the tumor was. And this really delivers just limited radiation to that cavity. It does not go beyond that field. It drops off pretty rapidly. We deliver approximately 60 gray at 5 millimeters depth of the tissue. The most common scenario when we use this is really recurrent glioblastoma at this stage. I'm a big fan of treatment more for metastatic tumors with the therapy, just due to the nature of how glioblastoma spreads. It is not simply a local progression, but it does tend to spread along the tracks of the white matter tracks. So, as you know, the arm of the body can be on the other side of the brain already, and if that's how the tumor spreads, local radiation at the body level is not going to affect the hand that's on the other side. I thought the easiest way for people who are not in medicine to see is to simply see this in action. So this was a patient with a recurrent GBM, and the tumor has been removed, and the tile really looks like a little sponge. You can see one white one in depth, and then the temporary patty that I used to plan the alignment. And this is really after the tumor has been removed. The tile gets placed directly on the surface in the cavity, and we are careful about not to overlap it. And we then seal it in place with glue. And that's what GammaTile therapy is. It takes usually less than 5 minutes to complete at the end of the removal the tumor. So very simple for surgeons to do. Obviously, there's a whole team behind it. A lot of planning is needed up front. Radiation oncologists determine dosing. We have the physicist coming up with the plan and do all the appropriate safety radiation things that have to occur in the OR. But from a surgical standpoint, it is not anything extra that would delay or prolong treatment in surgery. I think the early data on GammaTile was encouraging, particularly in the recurrent or progressive tumor world. The recurrence-free survival at 2 years for meningiomas and metastases was much improved compared to previous therapies. And I want to say that those are not randomized control studies. Those are the early studies that were done after feasibility and safety confirmation. So this is early data. Likewise, recurrent GBM survival was much prolonged after GammaTile therapy. But there's really a need for randomized control studies to really prove the benefit of the therapy. And you can see that the pre-commercial availability of GammaTile study really was predominantly on glioma patients. So those were predominantly GBM patients, fewer meningiomas and fewer metastases. After it has become available, the metastatic tumor world has significantly increased because it makes a lot of sense with those patients. There's desperate need for evidence in any therapy that we do. It is not just exciting technology that drives us. We need data to prove that it actually makes a difference. And likewise, GammaTile continues to register patients for use, looking at outcomes, and really the main trials are for recurrent tumors early on, and they're moving into the primary treatment of tumors. I think the ideal patient is really someone who's had cancer, has a solitary brain metastasis. So that's a single brain tumor that's of significant size that will require surgical treatment. Because in those patients, if they are systemically controlled, they can still get cure. And we've shown that with surgery and subsequent stereotactic radiosurgery. But imagine that patient comes for surgery, they don't have to have multiple visits for subsequent treatment later on. At the time of the removal, the GammaTile is placed and they're receiving radiation there and then, which then drops off, and they're finished with the majority of the treatment by the time they would have normally received their radiation. So it's sort of a one-stop shop for those patients with metastasis. And I think that that's exciting. Certainly in my world in Idaho, where patients travel many hours from rural areas, for them to avoid multiple trips to healthcare facilities is very helpful. And I think those things get missed in our trials and in our data collections. But it's the convenience of life, because it may be limited since we're dealing with brain cancer. And I think the future trials, I think that are starting in 2022 really are those with using GammaTile with primary glioblastomas up front. Like I said, there's a difficulty of making sure that it's the correct diagnosis, and then also combining it with tumor field therapy in the Cadence trial, where patients, this is on recurrent tumors where they're being treated with tumor field therapy, then they require potentially resection. They end up with GammaTile with their first re-resection. And then obviously locally recurrent glioblastoma trial is essential, because we have been using the therapy in such a way, but we really don't know what is the long-term data gonna be. I think that's just a quick touch on GammaTile therapy, and obviously thank you for listening, and hopefully I stuck to the time limit. I know neurosurgeons are terrible with time, and we, as demonstrated by my previous colleagues, I'm gonna make up for it. But I would be happy to entertain any questions, and obviously I'm eternally grateful predominantly to my patients and colleagues and their families. Really,
Thank you so much, Dr. Choutka. We do have some questions that came in. Let's see. One question was, so if you're using GammaTile, what happens to it? Is it removed or does it just disintegrate, so to speak?
I think disintegrates would be a better term. Yes, it is not removed, and that collagen sponge is totally absorbable. And even in the past, when we used only isolated seeds, those seeds were there, although they were not together. So you'd be doing scans down the line, and you find a little seed that was placed near a ventricle that migrated down and ended up somewhere in the spinal canal. It is no longer active, but it can move.
And so no damage, no nothing. It just
No.
is there. Okay. There's a nice comment that came in. Love Saint Al's. Wonderful patient-centered care. I had the privilege of serving on the Saint Al's Foundation board in Boise for 2 years. They do truly treat you like a family. Let's see. I've got another question. I just have to find it. Sorry.
Do you mind if I ask one real quick?
Oh, please.
Okay, well, this is Shannon, and I've actually had GammaTile therapy, so I'm particularly interested in what you had to say. I feel like I learn something new every single time I hear anything about it. But I just wanted to kind of ask, have you ever done anything like where, like, since I've had GammaTile, obviously I can be reopened again and have it put in again if I need to have another brain surgery. But have you ever like paired it with Optune? So say if I have to have another surgery at some point, could I have Optune also at the same time afterwards?
Yes, and that's actually going to be part of that cadence trial. So
Okay.
where the tumor field therapy is Optune, and so you would be perfectly that kind of patient where it can be done.
Okay, perfect. Thank you. And thanks for your presentation.
How well known is GammaTile within the brain tumor practicing physician population?
I think really it has expanded over the last couple of years. I think if you look at GT technology website, they run a map of all the centers that are registered and that participate in treatment. And obviously the map is much smaller than the map of cancer centers or radiation facilities around the US. But it has expanded significantly. And I think the convenience factor is one not to miss for patients. They can do that. But I don't think we're there yet in terms of that being a standard treatment. So we're still in the recurrent tumor world. It has not.
Yes.
It has not entered any standard therapy.
That's an important discussion. This treatment option is FDA approved, but like Dr. Choutka said, it's not standard of care. So that's really important for patients and caregivers and family members to understand. There are FDA approved treatments, but they're not part of standard of care. So that's part of that access issue. So the biggest part is to, first of all, know about it and other treatment options, right, that are FDA approved, but they're not being offered to you because they're not part of standard of care. And so you just have to ask. You have to keep asking, and you have to keep finding the healthcare team and the specialist who will be able to offer you what you are asking for. I know that sounds backwards, but that is the reality of where we live in today related to advanced treatment options for brain tumors and brain cancer. A question came in. I'm not sure I understand it, but I'm going to read it exactly as it says. This can be used even after a patient already had radiation to same area, ?
Correct. That is the most common scenario when we actually use it, because there is a limit to the amount of external radiation that patients can receive in their lifetime to a particular area. And because of the low profile on quick drop off of the radiation, this can be still used in a similar area and still provide the benefit without the harm.
Great.
I'd like to touch still down on your point. Yes, the key is we don't take it lightly as far as standard of care goes. If you go to any tumor board meeting between oncologists, radiation oncologists, and surgeons where we discuss any cancer, the first thing that comes up are always guidelines and standard of care, and has that been met? But I also do believe that medicine needs disruptive teams and disruptive physicians who will end up with cure. Childhood leukemia was only cured because of disruptive physicians. Each individual component of chemotherapy for leukemia in childhood was already tried, but it wasn't until the combination of the 4 different drugs was tried that we've actually been able to achieve cure.
Well said. Thank you. That's actually part of what the Ending Cancer Initiative tries to do as well. It's disruptive in care in order to help provide increased access to treatments, advanced treatments, and clinical trials and diagnostics as well. Mark is here. Mark is part of the GammaTile team, and he says in our initial trial that won us our first FDA indication, our average patient had 70 gray same site radiation, at least 2 previous rounds of radiation. So that's important to know that you can have had, if I understand this correctly. Mark, are you here?
I am. Hi, Delanne.
Hey, Mark, how are you?
I'm good. I'm on the East Coast, just dealing with, we had a death in our family, so I'm just kind of remote.
I'm sorry.
No, it's okay. It's okay. I'm here. I'm listening in. So happy to be here and happy to help answer any questions.
Yeah. Did you want to elaborate on that just a little bit?
Yeah, I mean, really, to break it down is this technology was developed for patients out of desperation that have received radiation after radiation and have run out of options. So that's kind of how the founders started with this. And the average patient had at least 2 rounds. So it could have been the initial Stoop therapy and then a additional gamma knife or other SRS treatment or something of the like, and GammaTile was still placed. So as Dr. Choutka said, that is who it is ideal for at this time because it's so targeted.
Mm-hmm, mm-hmm. Thank you. Thank you. Let's see. I might have just screwed up something. Somehow I got into something else. Don't know. I got out of my Zoom meeting somehow. Sorry. I'll tell you what. Are there any other questions for Dr. Choutka?
Nobody calls me that, Dylan. Everybody calls me Ondrej.
Oh, I can call you Ondrej. I'd be happy to call you Ondrej.
It makes me feel like I've done something wrong.
Oh, yeah. So sorry about that. All right, Ondrej, from now on, you got it. Okay, so just so you know, I'm not seeing my screen. I'm hoping all of you are still seeing your screen. And yes?
Yes, and I saw Asha Parker raising her hand.
Huh, okay, well, I'll do my...
So Ondrej, could I ask a quick question? Is are insurance companies okay with the cost of GammaTile, or is there some challenges with that?
There are challenges, obviously, because there is cost to any technology, and we have to go through approval with every patient. So it is reimbursed, and insurance companies do cover the cost, but to what degree it varies by insurance providers.
Excellent. That's something that we can work on actually together. Someone made a comment, this wasn't offered at. This is not offered at a lot of places, right? GammaTile is increasing where it's available at, but just know, you know, it, like other treatments, are not offered at every place that you're being treated at. So just know that. There is a link to the FDA GammaTile approval, which we can actually send out to you as well. So we'd be happy to do that. Let's see. Again, GammaTile is approved by the FDA, just looking at the comments here. Okay. Are there any other questions, comments for Ondrej? No? Okay. Again, I really want to thank you for joining us today, Ondrej, and for presenting and being so flexible with your schedule. I really appreciate it. Thank you.
Not at all. It's been a pleasure, and
we'll put up your contact information as well. We'll get that out to everybody. Okay.